of remarkable individuals, it is now my pleasure to introduce you to your next SCCM president. Jerry John Zimmerman was born and grew up in Reedsburg, Wisconsin, in an area of the world where dairy cows outnumber people. At that time, the population of his hometown was 5,280. During his formative elementary school years, Jerry developed a special interest in science and mathematics. He would go on to attend the University of Wisconsin in Madison for 16 years, obtaining a Bachelor of Science in Biochemistry in 1970, a PhD in Oncology in 1975, and an MD in 1979, and he did his pediatric residency training from 1979 to 1982. During medical school and residency, the focus of his interest became pediatrics. However, when he had his first pediatric rotation in the pediatric ICU, he knew that's where he wanted to be. Jerry interviewed for a fellowship position at all of the 5 available programs at that time, and ultimately chose Children's Hospital National Medical Center in Washington, D.C., where he would be trained by leaders such as Peter Holbrook, Alan Fields, and Murray Pollack. Jerry put his biochemistry background to work under the guidance of future SCCM leaders, Joe Perillo and Henry Mazur, at the NIH Clinical Center, and it was at this time that Jerry joined SCCM. As the society was still quite young and small, this gave Jerry the great fortune to personally interact with SCCM founders and celebrities like Max Harry Weil and Wilman and Norma Shoemaker. Continuous involvement in SCCM since that time has been a hallmark of Jerry's career. In 1989, Jerry became a fellow and charter member of the American College of Critical Care Medicine. In 1992, Jerry was appointed to the Critical Care Subboard of the American Board of Pediatrics. Since 1993, Jerry has served as book review editor and editorial board member for Critical Care Medicine and Pediatric Critical Care Medicine. He has served as a faculty member for all the SCCM Pediatric Board review courses. Jerry was elected to the SCCM Council in 2010 as the designated seat for the pediatric section. Since that time, he has served on multiple SCCM committees and task forces. Jerry has also received many awards and recognitions in his career, including the Lifetime Achievement Award from the American Academy of Pediatrics, section of Critical Care Medicine. During his career, Jerry's research has evolved to address diagnosis, treatment, and long-term outcomes of children with sepsis. Accordingly, he has partnered with ImmunoExpress in Seattle, Washington, to validate gene expression signatures to differentiate non-infectious from infectious causes of systemic inflammation. He is co-principal investigator for the planned SHIPS, or Stress Hydrocortisone in Pediatric Septic Shock, multinational, multi-institutional, randomized control trial that will examine potential benefits and risks of hydrocortisone prescribed as adjunctive therapy for pediatric septic shock. For the past 5 years, he has served as principal investigator for the LAPS, Life After Pediatric Sepsis Evaluation, multi-institutional, prospective, descriptive, cohort investigation that will describe long-term functional status and health-related quality of life among children surviving septic shock and examine variables related to provision of critical care, individual characteristics, and environmental factors that predict the extent and trajectory of recovery, baseline health status among children surviving septic shock. Jerry says that his life journey has always been interesting and frequently exciting, noting that it is an incredible privilege and humbling responsibility to participate in healing in the lives of the world's most vulnerable population, and the personal rewards associated with involvement with multidisciplinary critical care clearly outweigh a lifetime lack of sleep. Please help me welcome our 2018 President, Dr. Jerry Zimmerman. Congratulations.
Well, good morning, SCCM. How you doing? Good. And Ruth, thank you for that kind introduction. And how about that great musical fanfare from ZZ Top, the little old band from Texas? All right, thank you. It is my distinct honor to be with all of you here today, the most fortunate men and women in the world. We are all critical care health professionals, clinicians, researchers, administrators, teachers, and most importantly, we are patient advocates. We have this amazing privilege and awesome responsibility of serving the most vulnerable patients in the hospital. And this, my friends, is something that all of you should feel really good about. At the same time, however, we critical care health professionals are also vulnerable. We are vulnerable to the erosion of our work engagement. When our energy turns into exhaustion, when our involvement turns into cynicism, and when our efficacy turns into ineffectiveness. If any of this sounds familiar to any of you, make a point of doing something nice for yourself on a regular basis. Because practicing wellness is the foundation for avoiding our transition into burnout, and practicing wellness is the starting point for increasing value in the ICU. Last December, SCCM hosted a national summit with our critical care collaborative societies to address this issue of burnout in the ICU. And this meeting focused on a variety of strategies that can be implemented by clinicians and administrators alike to promote the health and the value of our critical care workforce. A special recognition to our most junior colleagues who've joined us here today. You are the next generation discovering critical care at the beginning of your careers. Probably you have already discovered, like the rest of us, that multidisciplinary critical care is where the action is, where truly meaningful professional rewards are to be found, and where SCCM has been since its inception in 1970. And if this is your first SCCM Congress, allow me to extend a very warm welcome from all of your Right Care, Right Now colleagues. I'm proud that SCCM includes an outstanding support system in the form of our professional organization. Because of the foresight and hard work of our member leaders, creative community, and partnership with our professional staff, SCCM has enjoyed year after year of meaningful accomplishments. And some of these, which Ruth just summarized, will allow us to reach even higher levels of achievement in the years to come. Now, in case you've just been too busy binge watching the latest episodes of Stranger Things or The Crown, allow me to just highlight a few of these accomplishments. SCCM international engagement continues to grow. We have over 60 countries, 60 nations represented here in San Antonio this morning, from every continent in the world except Antarctica. And trust me, we are working on that one. SCCM's PCOR ICU and ICU liberation programs are now setting the clinical standard for how we practice usual care in the intensive care unit. And we are understanding more and more the role that we must play after our patients leave the ICU and leave the hospital, and our Thrive initiative is at the forefront leading that discussion. Our new SCCM Discovery Critical Care Research Network has made substantial progress over this past year, recently submitting multiple research proposals to a variety of extramural funding agencies for consideration. And in addition, the first intramural SCCM Discovery grants totaling $100,000 will be awarded at this meeting to promote multi-institutional critical care research. I would encourage anyone who is interested in clinical or translational intensive care research to become involved with and take advantage of the numerous resources that are provided by Discovery. The goal of Discovery is to exponentially increase research in our field and then use SCCM's existing broad base of programs to disseminate these research findings into clinical practice. And after interaction with the leaders of this program over the past 2 years, I am confident that we are on the road to Discovery success. Sepsis 3.0 is now being debated all over the world. And I think this is a great thing because it is bringing sepsis into the public and the political limelight where it needs to be if we are going to impact the fact that every 3 to 4 seconds, someone in the world dies of sepsis. 2 decades ago, this almost feels like it was yesterday, SCCM catalyzed a new effort aimed at the world's leading killer. And as you know, the Surviving Sepsis campaign is now an international collaboration that provides expert guidance on the care of patients who have begun this deadly spiral of sepsis-mediated organ dysfunction. Today, SCCM members are involved working on forecasting that organ dysfunction, alerting clinicians to those patients, infected patients, who are at greatest risk for needing life-supporting care beyond just fluid resuscitation and antibiotics. Now, I want to tell you about tomorrow. Recently, a group of clinicians, mathematicians, statisticians, computational biologists, material scientists, and software engineers, as well as immunologists, met at SCCM headquarters to consider an even more audacious goal. The goal of preventing sepsis altogether by avoiding this transition from infection to organ dysfunction. So a new SCCM collaborative involving the Lawrence Livermore Laboratory will set as its initial milestone, get this, saving 1 million lives from sepsis over the next decade. So from surviving sepsis to forecasting sepsis to preventing sepsis, wow. Realization of this value stream will be truly transformational. So, these are just a few of the things that your society is doing to enhance value, to improve patient outcomes. The question now is, how are you personally contributing to this goal? While our many SCCM programs may be global in nature, as you all know, patient care is local. And of course, there are many ways that you can individually contribute to providing high-value care. That is, high-quality care at lower costs, as all of us are increasingly faced with sicker patients, more crowded intensive care units, and more limited resources. Continued performance improvement, in this case, talking about enhancing value in the ICU, begins with each one of us, individual practitioners, identifying a problem, knowing there must be a better way, and seeking out a way to find it. Either individually with local coworkers or as part of SCCM's global network of critical care providers. So with that prelude, may I, as your incoming president, offer a suggestion or two about individually, personally improving value in the ICU. First and foremost, I guess, in my heart, as those who know me will attest, is my commitment to ensure that our specialty does its part in controlling the out-of-control cost of health care. Are you aware that 1/3 of all care delivered in the United States is considered to be wasteful? And this waste is associated not only with financial harm, but physical and emotional harm as well. In fact, it's been suggested that waste or overuse be considered as an adverse event and reviewed in the same context. At the bedside, we critical care health practitioners can help control cost if we acknowledge one simple principle, and that is less is more. So we could continue this discussion with the idea that just because we can doesn't mean we should. And I would like to see that idea, just because we can doesn't mean we should, inscribed on the door of every ICU patient room. And this should be one of our thoughts as each of us enters a patient's room. Next, here are a few what I would call common sense, grassroots practices for cutting costs and, as a bonus, improving quality. 1, don't order diagnostic tests at regular intervals. 2, don't transfuse red blood cells to hemodynamically non-bleeding patients with an adequate hemoglobin concentration. 3, don't prescribe parenteral nutrition to otherwise adequately nourished patients during their first week of stay in the ICU. 4, don't deeply sedate mechanically ventilated patients without a specific indication and without at least daily attempts at trying to lighten that sedation. And 5, don't continue life support for patients who are at very high risk of death or severe impaired functional impairment or recovery without also offering comfort care only. Well, you know these are not my ideas. You likely have recognized that I have paraphrased them from the program Choosing Wisely. In a recent survey that actually was spearheaded by Ruth Kleinfeld as part of our Critical Care Society's collaborative, members were queried about their knowledge of choosing wisely and if their organization had initiated any quality improvement activities related to this initiative. And it's clear from the results of the survey that many of you already embrace the logic of choosing wisely and are involved in a variety of programs to decrease the waste associated with the provision of intensive care. And about this less is more concept, here are some additional ideas. Less fluid, less oxygen, less antibiotics, less radiographs, and less immobilization. These currently are not aspects of choosing wisely, but perhaps they should be because they are all derived from evidence-based medicine concept. Value-based care begins with the understanding the true cost of care, and then measuring and optimizing both short and long-term patient-centered outcomes. Remember that costs related to ICU care include not only the treatment of the patient's primary illness or injury, but also the cost of unintended intensive care misadventures related to the provision of usual care. And herein lies the beauty, the value of the SCCM ICU Liberation Program and the evidence-based A, B, C, D, E, F bundle. So A, always, of course, always prioritize the treatment of pain. B, undertake both daily scheduled spontaneous breathing trials and spontaneous awakening trials. C, be cognizant of the choice of drug classes that are being utilized for sedation. D, monitor for and minimize delirium. E, facilitate early mobilization. And certainly last but not least, engage and empower the family and the care plan. For ICU liberation, less is more weaning the sedation, weaning the mechanical ventilation, and weaning, or at least minimizing, immobilization. It turns out that the biggest waste in medicine is really waiting. We critical care health professionals are literally charged up with our own stress response during a resuscitation. This is what we do. But admit it, once our patients become stabilized, we are much more reticent to disturb the status quo. The unwritten engine of ICU liberation is weaning, titrated withdrawal of support in real time based on normalization of some aspect of homeostasis that promotes continuous advancement of care. So scheduled, not haphazard, but scheduled assessment and weaning when it's safe to do so, will reduce waiting and it will enhance value in the ICU. So practically speaking, how can we individually improve the value of care that we provide our critically ill patients? First, begin with one or more elements of choosing wisely. Second, incorporate the ICU Liberation A through F bundle as usual care for every ICU patient. And third, promote a learning healthcare environment in your ICU. This is where clinical care, research, and quality improvement are so integrated. They are so intertwined that they are basically inseparable. And this practice model will facilitate discovery of evidence to support best practice that includes improving value by practicing less is more. So there's lots more evidence-based medicine in the works related to promoting value in the ICU, so stay tuned to the SCCM website to stay up to date. Meanwhile, we should treat our patients and not laboratory test results. This practice will encourage all of us to get away from the computer and spend more time at the bedside. We should develop and we should utilize clinical standard work. This practice should derive from evidence-based medicine whenever it is possible, and inclusive consensus building when evidence does not exist. And finally, wean when it's appropriate, but at the same time, don't just think that you always have to do something when in fact, watchful waiting may improve clarity. This practice will frequently allow us to foster the concept that less is more. Achieving high-value care for our critically ill patients must become an overarching goal of our critical care delivery, because this goal matters to patients and families, and it unites the interest of all healthcare stakeholders. When value improves, patients, payers, suppliers, providers all benefit, and the economic sustainability of the healthcare system increases. I would respectfully challenge each one of you in the audience today to become the role model at your institution, regularly advocating for the concept that less is more. And to help you do this, I would invite each one of you to pick up some less is more buttons. As you leave the ballroom today, take some of these buttons home to your ICU colleagues, wear the button daily, and embrace the mantra that less is more. So we obviously have a lot of challenges and opportunities ahead of us related to improving value in the intensive care unit. And it will take everyone in this room to get the job done. But we can do this. We are a great specialty society, a great professional society, and like good leather and fine wine, we are, with age, destined to become better and better. I want you all to leave this meeting with the assurance that your society is committed to providing the leadership and the support that we all need to do our best job as critical care specialists. And I look forward to working beside you during the year ahead to advance this cause. In the days to come, if you're interested, I would like to share my SCCM presidency adventures with you. You can keep up with my activities representing our society by following me on Twitter, or you can drop me an email at the address shown on the screen. So speaking of improving with age, I would like you to meet some family members who have joined me here today to help me celebrate this tremendous opportunity to serve as your president. I would ask that they stand as I recognize them and that you hold your applause until all have been introduced. So first and foremost, my wife of 22 wonderful years, Jane Stevens. Lady Jane. Our daughter, Marika. Her husband, Jay Schneider. And their daughter, my granddaughter and the diva of the family, Madison. Thank you for your patience, your understanding, and your unwavering support. Thank you. Thanks also to my parents, Evelyn and William Zimmerman, my aunt and uncle, Amy and Pat Wills, my sister, Jane, my brothers, Norman and Bill. And thank you to all kinds of teachers, leaders, mentors who have taught me along the way. And here I would especially remember colleagues at Children's Hospital National Medical Center in Washington, D.C., the Upstate Medical Center in Syracuse, New York, the University of Wisconsin, go Badgers, and the UW Children's Hospital in Madison, Wisconsin, and of course, Seattle Children's Hospital and Harborview Medical Center as aspects of the University of Washington in Seattle. A very special thanks to Ruth Kleinfeld, David Martin, Diana Hughes, Lori Harmon, Lynn Retford, and Brian Schramm. Thank you to the pediatric section of SCCM. It's how I got here. And thank you to the SCCM Council, college, committees, creative community. Behind the scenes, these are the real worker bees within our organization. With an SCCM membership of 370, I have witnessed myself much gold standard leadership within this organization, and I have personally benefited from this very rich resource of talented personalities. And finally, although they're not with us here in person, they certainly are in spirit, patients and families who really are the source of all of my learning, and I would guess all of our learning. So please join me in thanking everyone for what they do, for what they have done to enable me to serve our society. Thank you for your continuing support of the SCCM mission, which is to ensure the highest quality of care for all critically ill and injured patients. And thank you for being with us here today at the 47th SCCM Critical Care Congress. Now, let's have a great meeting. Thank you.